All right, so we're going to jump right into our last presenter before lunch, and then we'll have a nice hour for lunch and come back with some great sessions in the afternoon. So we've had the national perspectives from Dr. Larson with CMS and Sam from the NCQA side. Thank you again both so much for coming and presenting those perspectives. So let's zoom in a little bit back down to Michigan. And we are lucky enough to have Tom Curtis over here ready to present. And he's been an excellent partner, discussing with MyHIN all these strategies for the Michigan Medicaid quality reporting and the various programs going on there. So Tom Curtis serves as the Quality Improvement and Program Development Manager in the Medical Services Administration at the Michigan Department of Health and Human Services, MDHHS. A lot of acronyms. In this role, he's responsible for establishing, administering, and evaluating Michigan Medicaid's managed care quality monitoring, reporting, improvement, and performance incentive programs for Michigan's nearly 2 million Medicaid managed care beneficiaries. In addition to these duties, Tom is responsible for working collaboratively with Michigan Medicaid's health plans on initiatives for population health improvement, health equity, and payment reform. Prior to this role, Tom directed Michigan State Innovation Model's SIMS demonstration project. Tom worked previously as a senior quality analyst with the MDHHS Managed Care Plan Division and a project coordinator with the MDHHS Division of Chronic Disease and Injury Control, where he developed partnerships with Medicaid health plans and community agencies. He holds a Master's of Public Administration degree from Central Michigan University and is a former health policy fellow with the Center for Healthcare Research and Transformation. Tom developed his passion and commitment to health equity and addressing social determinants of health while working at Allen Neighborhood Center in Lansing. Please join me in welcoming Tom Curtis.
Good. I guess it's still morning. Good morning, everybody. A little bit more before we get started about me. You could probably call me a laggard. So that'll come out in my slides. They're not as pretty as the last one that you saw. I don't have Facebook. I think I started texting pretty furiously maybe a year or so ago. I still really value a phone call, and I despise email. But nonetheless, how do I do slides, Bo? Yeah, see? There's right there. Is this it? That doesn't look like... Oh, wait. There we go, I got it. The big green button. Okay. So part of the reason that I wanted to give you that sense of who I am is because I'm the one directing this stuff, right? So you got a laggard in office, so to speak. But here I am at a technology conference, and we do have a lot of conversations in the department about how to advance technologically, but also sort of our measurement science and our contracts and our policy levers to improve and sort of innovatively advance quality measurement and quality improvement. But what I'm going to try to do is give you a sense of like what everybody's up against, right? So what are we currently doing as it relates to quality measurement and quality improvement and incentives and such? What sort of dynamics or factors do we have to take into account to give this audience a sense of sort of what you're up against, so to speak, when it comes to working with state government on innovation? So that's hopefully what I impart with you all today, but also give you a sense of where we are going, given all the constraints that you're going to hear and opportunities also that you're going to hear me talk about. Here's what we're thinking about moving forward. So want to continue the collaborative conversation with you all and do that in a sense of here's our reality. So I'm going to give a quick background of our Medicaid program. Is that too loud? No? All right. Quick background of our Medicaid program, our current approach, some of the recent changes we've actually been working to implement soon, fiscal year 19, and then sort of our future plans and how we're working towards that. So real quick, we have 11 managed care Medicaid health plans in 10 regional service areas. Just to give you a sense of what that actually means, in one region, the Upper Peninsula, we have one plan. But then in Region 10, which is Southeast Detroit, we have 8 Medicaid health plans. So when people talk about multi-payer alignment, we do that on a regular basis, and we have to. We have 11 different payers that we have to align and come to agreement across. So never mind getting into commercial alignment or Medicare alignment. We're doing it on a regular basis just within our managed care program. 2 million plus beneficiaries, primarily children, moms, pregnant women, but also the expansion population. We do have the Healthy Michigan Plan, Medicaid expansion population here. We did carve in foster kids and children with special health care services, or CSHCS, and then age blind disabled. All right, so I'm going to go through sort of what we do currently with measurement and monitoring, what kind of incentives we have on the table for our Medicaid health plans to perform relative to that measurement and monitoring activity, and then some of our new projects as it relates to population health. So measurement and monitoring. First and foremost, we do a quarterly what we call performance monitoring report. Historically, this has been administrative measures, so claims, processing, timely and complete submission of claims, and it really points back to contract language that we have that folks have to submit complete and timely claims up to, I think, 95% or so of their submission. So it's really monitoring compliance to a contract. We also require all of our Medicaid health plans, so all 11 of them have to be accredited HMOs to even just get in the door here in Michigan. And that's not true in every managed care state, but it is true here. You have to have an accreditation as an HMO just to accept one member. And we also require them all to submit NCQA HEDIS rates to the state that are audited. So we publish HEDIS rates, we publish administrative measures, and then we are increasingly getting legislatively required measures, and this really has most pertains to the Healthy Michigan Plan Medicaid expansion population. So there are specific measures associated with making sure folks are on time paying their co-pays and their contributions and doing their health risk assessments and getting into a doctor within 6 months, that sort of thing. But we also have mandates for blood lead screening, so we have to keep track of what the legislature is requiring of us and keep measures in front of the plans to adhere to. We publish an audited HEDIS aggregate report every year, and then we require plans to submit programs and policies and procedures related to their population health programming. So this gets into what are our Medicaid health plans doing around social determinants of health? What sort of key determinants beyond medical care are they listening to their members about and surveying their members for and attending to with their care management or community health worker programs, which is what you see next. And then finally, health equity, and this gets into sort of the tenet we have in managed care, and that is you're not doing population health unless you're doing health equity. So we're not throwing population health improvement out in front of our plan saying this is another exercise of going after the low-hanging fruit. This really is, if you want to pursue equity and outcomes across an entire population, you got to start with the subpopulations that are experiencing poor outcomes and look at that by race, ethnicity, and look at that by gender, et cetera. So really, this is new, at least for the state and our plans. In 2016, this actually was put into the new contract because we just re-procured in 2015. But this is a staple and an increasingly larger component of our program moving forward. So in terms of incentives, I'm going to talk about, I think, just two incentive vehicles that we operate. The first is the 1% capitation withhold bonus pool. So based on the amount of total capitation payments that we provide to all of our Medicaid health plans, we sort of slice off 1% off the top and create a bonus pool. This coming year, we're really roughly estimating it at about $65 million. So we use this bonus pool to reward plans on their performance in audited HEDIS rates, CAPS rates, as well as legislatively mandated rates. And let me talk about those two first, because this gets into standard setting, right? So this is how what operationalized the incentives for us. So when it comes to HEDIS audited rates and CAPS measures, those benchmarks are sort of set for us. So we can point to a 50th or 75th or 90th national percentile benchmark and say, we're not going to just compare ourselves to ourselves. We're going to compare ourselves to the entire country. And it's all audited. It's reliable and valid. So in terms of incentives, it really helps us not fight about the accuracy of a rate and really just sort of calculate incentives pretty simply. The legislatively mandated, however, those were measures created by us for the most part, and so we really have to look historically and set standards based on where we see health plans sort of fall in the spectrum, and take into account sort of what type of priority is that legislative mandate to the department itself, and sort of take all of those things into account when it comes to a standard. I'm going to talk quickly about the behavioral physical health integration measures. So those, I think, came about around 2015, Jackie, right? 2015, we started a conversation with our Medicaid health plans and our prepaid inpatient health plans. So we have a behavioral health carve-out here in Michigan, so we have two different payers paying for behavioral health and physical health and dental. But we wanted to create some incentive to where both payer groups were pursuing a common measure, a common standard, and use bonus withhold pools on both sides of the equation, if you will, to pursue, really to encourage coordination between the two. That was really the goal. We started with follow-up after hospitalization for mental illness. We used the HEDIS specification, and this gets into how to another component of how to operationalize incentives and quality improvement. So one thing we have to make sure is that the specification is well understood and within the bounds of every single payer to operationalize. So if they have to reprogram systems, if they have to run their query and refine their query, for example, then we have to work with them to make sure they're all sort of doing it. Otherwise, no one's sort of at the equal playing field, so to speak. One thing we always like to do as well is make sure people are familiar with the specification for a fair amount of time and familiar with what the data says and what it shows so that they can restructure their care management or any sort of intervention that they need to do, because otherwise we're just measuring something for the sake of measuring it and no one gets an incentive. I mean, at the end of the day, I want everybody to win. I want everybody to get all the money that there is on the table, because that means they're doing well, and that means Medicaid beneficiaries are getting good care. But it takes time. This does take time. Typically, if we throw out a new specification, we will run that measure informational only for about a year. HEDIS really accelerates that process, because we say you got to submit all the HEDIS measures every year. And so we can track on a regular basis where something's at. And if trends are starting to dip, for example, we can talk about adding that to an incentive. But if it's a new measure to a payer, so for example, the follow-up after hospitalization measure was brand new for some of the prepaid inpatient health plans. So we had to do a couple years of process, data validation, so that we could truly use incentive to pursue improvement. We're moving forward, we're going to add measures to that list. So we're looking at plan all-cause readmissions for both behavioral and physical health, and ED visits for follow-up after ED for alcohol and other drug. So some pretty challenging measures, but nonetheless, definitely rates that we looked at internally and said, these are problems. We're not doing well at this. And then when we look at the racial disparities, we're really not doing very well at this. And so from a state government perspective, it's something we can't ignore. So we got to start getting it onto the bonus withhold, both with PHPs and the Medicaid health plans. So it's an opportunity. What it amounts to is the exact same contract language in both sort of sets of contracts. And then we work with Behavioral Health Administration to sort of manage and administer both sides of the bonus pool. The compliance review score. So this is another component of the withhold. So we have, a not a short contract, but there's a lot of legal obligations that our contracted health plans have to adhere to, and we make sure that they're adhering to them, and then they get a score as to how well they're adhering to all of their obligations in a manner that's consistent with one another and with what the state's expectations are. Finally, I want to say about half of that $65 million roughly next year will continue to go into what we call project development, evaluation, and implementation. So we recognize that it's not really a typical managed care organization function to pursue population health improvement, to pursue community collaboration, to necessarily stratify all of their population by race, ethnicity, for example, and pursue health equity. But that's important to the state, and we need to make sure that the functionality is relatively consistent across all health plans, because at the end of the day, I don't care what plan that beneficiary is a member of, they need to have the exact same opportunity as somebody else in a different plan to the best of my ability. Now, we know that's impossible, but we're using a lot of our withhold to due process with our plans around developing population health and health equity projects, and really monitoring to make sure they're in line, if you will, with the principles of those sorts of efforts. So it's been a pretty collaborative and interesting journey with them. We set up, and we continue to do so, what we call a pre-submission, final submission process with them. So we throw out sort of the rules of the game, and we say, we're looking for something like this. Look at this data, ask these questions of your members, then come up with what intervention you think is reasonable. They pre-submit it, we can review and provide feedback, and then they final submit for points. And it turns out to be a pretty good process the plans like, because then they get more of their points, but also they get a better sense of clarity from the state in terms of what it's expecting, or what we're expecting. Because it is sort of a game of we're not going to know it until we see it sort of thing. So we're looking for something like this, but we don't want to prescribe so much. Otherwise, why would we even privatize Medicaid if we want to just prescribe everything? But we want to leverage their expertise and leverage their experience with their own members and have them come up with some pretty innovative projects. And that's been going well since 2015. The second incentive vehicle that I'm going to talk about is the auto assignment algorithm. So for simple math purposes, about a quarter, and it changes quarter by quarter, but about 25% of Medicaid members that enroll in Medicaid, and then you're supposed to pick a plan within, I think it's 30 days or 45 days. About a fourth of them don't pick a plan, and so they get automatically assigned to a health plan, and their capitation payment follows them to whatever plan. So that's an opportunity from a state perspective. So we have an algorithm, or a way we calculate sort of what plan gets more auto assignments, and this is revenue for the plans, and they take it very seriously. But we use HEDIS in CAPS currently, so we compare them to 50th, 75th, and 90th. We also do provider capacity by county, and so this is reported by the plans, but they can essentially say, here's my provider capacity. Here's almost saying, here's the amount of folks I'm able to provide access and care to in these particular geographies. So at the end of the calculation of points, if you will, we put folks into what we call bands. So band 1 obviously is you get the most auto assignment percentage, and band 2 and band 3, and then band 4 is 0. So if there's a band 4 where just that the scores are so low that it's not in the best interest of the state to necessarily start handing members to a low quality opportunity, then we have a band 4 0 auto assignment. So it's pretty serious. I put $2 billion up there. That was last year. It was roughly $2 billion. The capitation was $8 billion last year across all of our Medicaid health plans, and so a quarter of that's $2 billion. But the point is, it's a lot of money. So I talked about this a little bit, but we are taking a lot of our energy into population health program development. So looking at social determinants and population health improvement, we have been doing an ED utilization project, but really trying to focus again on social determinants that are resulting in folks going to the emergency department, or at least how is that a contributing factor? So really trying to stretch health plan perspectives on beyond medical care and looking into the community to get some partners that can support them. The methodology that I talked about, that pre-post submission, gets into several layers. So we have them all do what we call a baseline analysis. So look at your data, talk to your members, do a barrier gap analysis, and then tell us what you really think the sort of root cause is. Then come up with a proposal and send in the proposal. And if the proposal doesn't map back to the barriers and gaps that you just described, then that's going to be a problem. We're not going to authorize a proposal that doesn't make logical sense. Then they'll implement, and then they'll report on 6 months, I believe. So these roughly run 12 to 18 months of intervention, and then they report their final findings. But they do have about a year of development and design, planning and design as well. So we don't want to just do something for the sake of saying we did it. We want to allow folks a concerted amount of time to make sure they're doing something meaningful and measurable. So recently, sort of under the tenets of the procurement that I described in 2015, but also as it relates to Michigan's state innovation model efforts, we've been doing some what we're calling alternative payment model programming in our managed care plans. So the objectives are to really increase the medical expenditures into shared savings, shared risk, full risk type arrangements. So show of hands, how many people have heard of the Healthcare Payment Learning and Action Network, or LAN framework of payment reform? Okay, just a couple. Real quick, it's a 4-category sort of spectrum, if you will, where category 1's fee for service. You get a category 2 that's more pay for reporting, pay for performance. Category 3's upside, downside, or just upside, gain sharing or risk sharing. Then category 4 is full and partial risk, like capitation payments. And this is categorizing payment from a payer to a provider. So that's an important distinction. So we want to increase the expenditures into that category 3 and 4 over time. Finally, improve quality of care for Medicaid beneficiaries. So we're not just doing payment reform, again, for the sake of doing it. It really has to make a difference in the lives of our beneficiaries. And finally, this was brought up in the last conversation, but enhancing consistency in measures across providers. So the key operative there is enhance, right? We don't have the authority, first of all, and second of all, I don't know that it makes entirely programmatic sense to just mandate consistency across providers. But the extent to which we can sort of make incremental inroads in requiring some consistency and have some rationale as to why we are mandating those measures, then we're going to pursue that opportunity. We have recently, this took about a year, but we went through a strategic planning and implementation plan process with our health plans, where they had to create a strategic plan. Here's how over the next 3 years I'm going to move into that category 3, category 4 direction. And then here's my 1-year implementation plan of the models I'm going to use, the provider groups I'm going to go engage and try to meet those strategic objectives. Real quick here, what we saw, and this is pretty rough calculations, but what we saw is in fiscal 15 and 16, we were sitting at about a 19% expenditure rate of payment models outside of fee-for-service. So in those pay for reporting all the way up to the full cap, it was about a 19. So that's all of them. Most of them in that category 2, pay for reporting. Over the next 3 years, the projections, and this was submitted by the plans themselves, but aggregate across our whole program, they're looking to increase that to about 30% into that category 2 and 4. So we took a little bit of a different approach than some states. Some states came out and they said, we're going to do 80% by 2020 or something, and we didn't want to do that, and we really wanted to have this born from the folks doing the operationalization of it, which are the plans, to say, what do you think is feasible? You sort of are all in different regions. You all have some different provider capacity circumstances. You all have different membership sizes, and so there's different factors contributing to their ability or not to really move in the direction. So we didn't want to come out with some arbitrary number. But just to give you a sense of what the plans have informed us, they're looking at not quite 20 to a 30% increase in payments made outside of fee-for-service over the next few years. We'll see how that pans out. But regional measures, the reason this is up here is it really gets into that partly the objectives 2 and 3 really. So what we noticed, just tracking expenditures is a good exercise, and it does give us a sense of sort of the payment innovation that's going on, and also the clinical integration that, quite frankly, probably Medicare and other payers have pushed in the market much more than the state government. But nonetheless, it allows our Medicaid health plans to sort of throw their hat in and participate in those. But what we wanted to do with the regional measures is categorize opportunities for quality improvement by region, by geography, not by plan. So this is a pretty new perspective. Usually things are very health plan centric. So you plan are bad at these measures and you got to improve. You plan are bad at these measures and you got to improve. We wanted to say, forget it. Health plan agnostic. What regions are doing poorly at certain measures? And so we actually ran some statistical analysis of some claims-based HEDIS measures out of our warehouse, our data warehouse, and did some comparisons and came up with, turns out it's about 6 measures over the 10 regions, so there's sort of duplicate measures, if you will. But we chose at least one that was so disparately low in that region relative to the comparison that we had to put it on there and essentially require it. If you're in this region, you have to do a payment model in category 2 through 4. We're not going to tell you which one, but you got to do a provider incentive beyond fee-for-service using this measure. And it can be a provider you already contract with. It can be multiple providers. But the plan is responsible to go in and say, all right, who's not doing well? Who's not doing well, and do I have an incentive on the table for them? And is it working? One thing we're going to sort of lift the hood on with this piece is how are standards being set by plans for providers. So it's one thing to say we've got an incentive out there. It's another thing to say that incentive is likely impossible for the provider group itself to achieve. So is the incentive actually real? That's sort of the approach we're trying to take. So and actually in Region 10 we have 3. So we have 3 different measures in Region 10. There was 3 that were so disparately low we couldn't ignore it. So they were required to incentivize on those 3 measures. So from a provider perspective in Region 10, for example, you're going to have some consistency for those 3 measures. There may be more measures that aren't consistent, but those 3 will be incentivized, assuming you're a low-performing provider in those across 8 different health plans. The incentive might be different. You might have a pay for reporting here. You might have a gain share here. You might have a partial cap here for PCMH. I don't know. But the point is the measure will be the same. And so at some point as a provider, and I'm not one, you might say, well, at least I'm going in the right direction with 3 measures across all plans. The incentives are different, but the bottom line is I'm getting incentivized for these 3. I think this is an important opportunity that I continue to try to say, what more can we do here? Is this a business case for HIE use cases, for example? It's one thing to sort of build the way to transmit the data. It's another thing to say, all right, providers, now you've got incentives across all these measures for 8 different plans in this region. So what's the business case to use the technology that we have available? Real quick, too, with Dr. Simmer in the room, so these regional measures also offer an opportunity to talk with folks like Medicare or other payers and say, well, we ran our analysis in our regions, and here are the measures that we're not doing well at. Does this resonate with you? To what extent are you experiencing the same sort of disparities regionally that we are, and can there be an opportunity to align in that regard? Doesn't have to be at an incentive level, but it does create some consistency in measure and therefore incentive and therefore that sort of business case to advocate and lobby for a consistent data collection and transmission process. Okay. I think I'm doing okay. I want to touch on this. This has been a pretty integral effort. It sounds maybe boring a little bit, but it's really been the way we've been able to really talk about the future plans that I'm going to talk about in a minute. So we created what we call a quality measure data work group. So we have a rules engine, and we're pulling claims-based HEDIS specifications out of our warehouse with our rules engine. And then we're convening all of our health plans, completely voluntary. There's absolutely no contract requirement or incentive that I'm putting on the table for this. But we're saying we're going to pull these measures, and we're going to provide you with your member-level data of who makes up your numerator, who makes up your denominator for these measures. And then you go look at your own systems. You pull it, and you tell us where the discrepancies are. So we've been doing this since August, and it's amounted to some pretty significant refinements in our own tool, recognizing we're never going to get perfect or accurate. We can't have one tool mimic 11 different tools when it comes to a rules engine, but nonetheless, or 11 different systems either. But we've come pretty close. I mean, within tenths of a percent with rates that plans are pulling. So in some cases, we have measures that we're pulling from a warehouse that are essentially the exact same measures that the plans are pulling from their systems. So that's an opportunity because it gives us the chance to begin stratifying our measures out of our warehouse in different ways and putting those on incentives and standing up to sort of the reliability and validity scrutiny, if you will. So I sort of just talked about this. So the quality measure work group itself has allowed us to begin looking at trends that we've known about. So in 2012, we started publishing what we call our Medicaid Health Equity Report. And this is looking at, I think now, 13 different measures. We pull them, we actually get it from the health plans. They pull from their IDSS HEDIS files and submit to us. Here's the numerator denominator counts by race, ethnicity. And then we do a comparison. So we compare Hispanic and African American rates to the white population, and we determine disparities that way. And we also do what we call an index of disparity, and that's basically taking the absolute value difference of each subpopulation relative to the plan rate itself, and coming up with an index percentage. We publish these in our PMR, and we will be in fiscal year 19 assigning 2 health equity measures to each plan, and the goal being to reduce statistically significant reduction in the disparity as it relates to the depending on the measure, quite frankly. So we actually, usually it's African American compared to white. But in some cases, we actually have reverse disparities. I guess the comparison would be the same, but the goal is different. So chlamydia screening is an example where we actually see a reverse disparity. Far more African American women being screened for chlamydia than white women. I think one thing that's relevant here is we want to go beyond HEDIS. I think that's sort of the way we talk about it. We want to go beyond HEDIS, recognizing the limitations that I talked about earlier, that throwing out a new spec is probably like a 2-year process. We have to get folks familiar with the spec. We have to make sure their queries are running fairly accurate, and they're validating and make sure our queries are running fairly accurate. Give them a year to look at the data and get familiar with the data, start thinking about intervention and care management if they're not already doing something, and then put it on the incentive and have hopefully a 3-year look-back period to set a standard as well. So we are looking at CMS core set measures. How many folks have heard of the scorecard that CMS just came out with? Okay. We'll just move beyond that. Prevention quality indicators is one that we're really excited about. Actually, 4 of them related to the short admission rates due to short-term complications for diabetes, COPD, heart failure, and asthma. So we're looking at those. We've also got some Michigan-specific measures for dental. So we're looking at preventive, restorative, and diagnostic utilization rates. Finally, as I mentioned, we're trying to increase our behavioral physical health integration measure set. The three I mentioned, there's sort of a lot more in the background, if you will, that we're looking at. One thing we need to make sure, though, is we score those by what we call PIHP-MHP combination. So one MHP might have 16, no, not 16, how many? 10 different PIHPs that they work with. So they have 10 different sort of combinations, and within those combinations, you have to have enough folks in the numerator denominator to be a valid rate to score. And so some of these measures they get so specific, and the exclusions start taking folks out, and you don't have enough combinations to score. So we are looking for more measures to add. Opioids is one that we're increasingly looking at for this purpose. And finally, just continue to leverage that quality measure data work group to go beyond HEDIS, if you will, and talk about other sorts of measures that are out there that are important to measure for our population and work with our plans to operationalize. Holy moly, I had too many slides. So finally, real quick, what we found when we rolled all of our population health management programs out in 2015 is we ended up having, like, we're going to do our ED utilization project here and our community collaboration project here and our health equity project here, and it was really splitting plans into like 4 or 5 different directions. So we're trying to bring those together and create some consistency. So they're essentially rolling out a common functionality and just looking at different stratifications and different factors within their population. So working towards that. So 2 slides on future plans. We are looking at, so as I said, we've incorporated 2 health equity measures into our capitation withhold incentive program for fiscal year 19. We are exploring the opportunity to do the same for the auto assignment algorithm. So remember, that's that billion with a B incentive vehicle, but really taking health equity to that next level and prioritizing it from a monetary standpoint. And a regional, right? So we do notice that there are differences in geography and in demographics. But there's also something that's very real called plan performance. So it's sort of all 3. Where are you? What sort of folks are in your plan? And what kind of plan are you? It's sort of all of them. But if we rely on HEDIS only and HEDIS audited rates, we're really only getting the third. We're only scoring the third one. We're not scoring them based on where they are and who's in their plan. And so we're really trying to take a more serious look at that. Expand our health equity measures, and something we sort of talk about and just never quite have the energy to move on towards, but it is getting into how do we quantitatively define population health improvement and create standard measures for our folks improving population health. Are they addressing social determinants, for example, and hold folks accountable for a standard as it relates to that. We will be, over the next year, setting standards for these beyond HEDIS measures that I talked about. And again, that wouldn't be possible if we hadn't validated the data with our plans and worked with them to see where the discrepancies were. But getting them to see the writing on the wall that we are going to move in the direction of using more measures and setting standards for them, and use our rules engine to expand the set, as I said, of behavioral health and physical health. And finally, one of the things the new managed care regulations did was it prohibited what are called pass-through payments. So now, if there was ever a pass-through payment, and so in this case, we would ensure access to hospital care for all Medicaid beneficiaries by calculating the payment that each plan would have to make to each hospital and say, here's the money, and you have to send it directly to these hospitals in these amounts, and they would do it. That was a pass-through payment. Now the new regs say you can't do that, so we have to do what's called a directed payment. Directed payment. So same thing. Here's the money. Here's the hospital. You have to pay it, but it has to be based on something, right? So it has to be based on some sort of measure, some sort of objective reason that payment is what it is, and performance is one of those. And so one reason why you see the difference in capitation withhold from 80 million to 65 million now this year is because that pass-through or directed payment now represents about 1.5 billion of dollars going to hospitals to ensure access to Medicaid members, and that's wonderful. But it also, we're not naive. That's an opportunity. That's an opportunity to leverage a significant amount of funding for hospitals to start looking at quality improvement at that level from a state perspective. And I don't know if there's any hospitals in the room, but I can assure you there's no reason to be alarmed or panic because this will be a similar collaborative process with you all as it always is with our plans as well. So at the end of the day, I want all the hospitals to win too. If I'm setting up an incentive quality improvement program and people lose, that's not good for anybody. So I just wanted to give you a sense of that. But that is sort of the new thing one of the new things on the horizon for us. And I think that's it for me. I want to thank everybody. I probably talked fast, but hopefully I met my goal in giving everybody a sense of what data sources we use and the realities we're up against when it comes to operationalizing new data sources or new measures in general. Especially when it comes to our incentive vehicles, if we can't assure that the capacity and the opportunity is the same across all plans, it really makes it difficult to put incentives on the table for this, because they will say, I don't have the same opportunity to win the money as another plan, and that's real, and that's serious. So, until it's possible, in an ideal world, right, all providers would be using this and submitting it all the same, and the plans would be, have the same capacity to incorporate and calculate. Then we could really have a meaningful conversation about how to use this and provider incentives. But until that, it's difficult.
Right out their mouth.
Absolutely.
First of all, thank you for the presentation and for the leadership that you're showing with our Medicaid programs. I think we're really moving forward under your guidance. My question relates from a Blues perspective. We tend to anchor our population management performance with the ACO programs, which are quite well developed in this state, and the Blues try to align with that. Where a gap has been created is that our providers who take care of children feel there really isn't a place for them within this model because it's so oriented toward adults, and the OSCs and Blue Cross or ACOs never get around to child health. And we used to focus so much on EPSDT, which I missed 2 minutes of your talk as I got pulled away, but I didn't see that acronym at all, and so I was kind of surprised. But I am curious, since there's such an orientation toward children within Medicaid, what type of leadership could we look toward as commercial health plans to Medicaid to sort of set the pace relative to population health from a pediatric perspective?
Well, I think the first step would be, what are you measuring and what are we measuring, right? That would probably be the first thing that we could identify, and are there commonalities? The second, I think, could be, here's how we are operationalizing incentives around where we do have common measures for our plans. And then finally, I think we could look at our APM program. So one of the important things around this payment reform process that we've set up is that it's on the withhold, right? So now we have dollars on the table that plans have to sort of perform in a certain way to get their dollars, and it gives us an opportunity to almost set policy in that regard. Excuse me. So if we wanted to look at pediatric measures where we're faltering, quite frankly, I think pregnancy might be more of an issue in our Medicaid population that we would want to target. But I think it still falls in line with your sort of life course population health approach. But if there are opportunities to align from an APM program, from a measure, and from an incentive perspective, that only makes sense. So I don't know if I'm accurately answering your question, but at this point, the pressure, and you sort of alluded to it, the pressure really is, how do you manage care better and reduce costs as quickly as possible. And it does. It always leaves out the preventive focus and the children's focus. So rightly so, you don't see it a whole lot in some of the improvement efforts. That being said, we did add several child measures to our health equity set. I guess I should have maybe added those, but we're still negotiating contracts, so I'm glad I didn't. But we do have several child sort of associated measures in our health equity projects. So we are trying to create that equity lens in that regard. But yeah, good question.
Kevin Larson from CMS. A number of states are working on a Medicaid quality rating system, which is a way for you to use the health plan quality data and other data as a way for consumers to choose their own health plan based on the kind of data that you collect. Are you doing something, or do you have tools or ability for that kind of visibility for consumers to make those choices based on your data?
Yep, we do. We call it our consumer guide. So actually our EQR vendor uses our HEDIS and our CAPS rates to calculate what we call our Apple system. So we have 1, 2, 3, maybe 4 apples, depending on getting care quickly, getting needed care, living with illness, that sort of high-level categories, and then there's composites within that determine the Apple rating, if you will. And then we create a brochure. We send them out to all the plans, to the local health departments, and to other partners. We also do a county-by-county sort of flip chart, if you will, of that Apple rating system, and we send that to our enrollment broker. So when folks call in and say, I need to get it on a plan, that's accessible. That information is accessible. More can be done, absolutely. But sort of that's what we generally have in place at this point.
Mary Joseph, great presentation. Thank you.
Thank you.
You started with talking about where you're at and expanded into where you want to go. I'd like to hear what you think your historical successes have been with these quality initiatives.
Well, it's a little bit of a difficult question to answer. I've been here about a year, but I guess I'll answer it this way. So one thing I'm increasingly mindful of is these pregnancy-related measures. And one of the reasons is, and I don't know if this is a national trend, I thought I looked at it and it wasn't, but in 2014, our timeliness in prenatal care measure was almost 90%. In 2016, it was below 80. So there was about an 11 or 12 percentage point drop in timeliness of prenatal care over a 2-year period. And it's definitely something that we clearly were doing well at. And there is focus from a sort of small QI project perspective in pregnancy care. So postpartum care, our rates were higher. Timeliness of prenatal care, our rates were higher, but they're dropping. And so there is an issue there. I don't know if it's been sort of this shift in focus to just reduce costs, having this cost crisis sort of cloud people's or shift people's priorities at least away from kind of the bread and butter of Medicaid, really, which is kids and pregnant women and moms. But it has been successful, and I think there's a lot being thrown onto Medicaid these days, right? So what we sort of we had a smaller set, a smaller scope, and we knew who our population was. It was the moms, it was the kids, it was the pregnant women. Then we carved in, and we've added all of these other populations. We've added all of these administrative stipulations to Medicaid expansion. We're talking about other administrative stipulations that takes people's time and energy, quite frankly. So where I think we saw a lot of success in that kids and pregnant population, we're seeing it fall away. We're seeing it slip away a little bit. So not really answering your question, but I do know that is an area where we typically performed very well at up until recently.
Hi, I'm Sam Benton. Thanks for the presentation. So I was wondering if you could clarify the regional measures. To identify them, were they the lowest performing in the region, or was it when you compared it to other regions? And then also, were you able to find out like any feedback from the plans? Was it because of they had trouble collecting the data, or was it like real health disparities that existed in their populations?
Yeah, good question. So first of all, we actually used our Region 10 as our comparison region. So that's Southeast Michigan, that's Macomb, Wayne, and Oakland counties. Partly because like 500,000 people on Medicaid live there, and so it was a high volume area. So we essentially compared each region to Region 10, and as I said, Region 10 had 3 disparately low measures. So if Region 1 was disparately lower than Region 10 on a given measure, we knew it was a big problem because Region 10 historically performs lower than all the other regions. So that's one. So it was statistically significant. First of all, was the test we use. But we compared all regions to Region 10. And then we also, sort of in that inverse comparison, we came out with those 3 Region 10 disparately low. Does that make sense? Okay. So the second question was plan feedback on the reason for the disparity. Yeah. So we're going to get that through our efforts with them moving into fiscal year 19. So this first fiscal year will be a process year. And so we're really saying, now that you know the measures and you know the rules of the road, if you will, go forth and identify your low-performing provider groups. Tell us who they are. Tell us where they're currently performing. Tell us what sort of standard you are going to set for them in your incentive program. And then the following year will be sort of the performance year. And then we're going to see to what extent they perform relative to the standard and put dollars on. So I don't know the answer to your second one, but I wanted you to know there's a process in place where we're going to start identifying those sorts of issues. Yeah.
Hi, Christina Dawkins, Heart Disease and Stroke Prevention Unit at MDHHS. What are the 3 disparate measures, and if you can remember any of the other ones from the other?
I knew somebody was going to ask me that. Timeliness in prenatal care is 1. I believe chlamydia screening is 1. And I really want to name the third one, but I don't want to be wrong. But I believe it is asthma, medication management for asthma. I'm sorry? Right. So one of the things, we started this sort of measure alignment conversation with plans a year ago. And we came out with, we essentially were like, these are the big problems: controlling high blood pressure, diabetes, and I think we had we had blood lead, and we had another one related to children. I think we had 1 or 2 related to pregnancy. So we tried to come at it that way. And the result was, well, these are hybrid measures. So if we were going to stand up a payment reform project with a provider, we would have to make sure we're getting every single bit of clinical information from them related to calculating this measure. Otherwise, we're going to face the same scrutiny as it relates to doling out incentives for performance that you all do with us. And since that capacity is not the same, it's not the same at a provider level, and it's not the same at a health plan provider network level, our set was more limited as to what we could roll out. So we had to go claims-based in order to make the determination and create that equal playing field across all our health plans that I talked about if we want to use withhold. Now, that's not to say that plans don't have the ability to get clinical information. They do. They absolutely do, and some of them are doing it far more than others. But without that, what we need to do is create a conversation where we're pushing them in the direction of all having the same sort of capacity to do this. And I think the ECDS NCQA is an opportunity actually to start that conversation with plans. But I think it's going to be a little bit slow moving because, first, the way I look at it is I got to put contract language in first, and then they got to go lobby their boards for probably more money because they can't implement ECDS, I'm guessing, with the staff that they have, so they'll have to get more staff, and then, so it's going to be probably a couple-year process before we really move into the ability to use something like ECDS to push our plans into sort of a common capacity of getting clinical information. So we couldn't use controlling high blood pressure, Christina, that's what I'm trying to say. We tried. Yeah.